And when you hear, there we go. Um, my first quote comes from DJ Jaffe, who was a dear friend of mine. He was a very well-known SMI advocate who wrote a very famous book called Insane Consequences: How the Mental Health Industry Fails the Mentally Ill. This was a wonderful policy book. It's one of the first books that I read that helped me to get an understanding of how did we get here? What broke down in the mental health care system in the country for people with the most severe illnesses, and what's our way back out? I highly recommend it. And he was quoted during one interview during a really important documentary called The Right to Fail. If you've never seen that, look it up. It was done on PBS. But he said, being in psychosis is not a right to be protected, but rather it's an illness to be treated. And boy, was he right. I cannot agree with him more. So when you hear people talk about mental health courts, what we're talking about in most cases are criminal mental health courts. And these are an important piece of the system, the continuum of care. We hate that this has to happen, but if somebody ends up going to jail for having committed some form of a crime because they are untreated, it's wonderful when there is a mental health court that they could potentially agree to be diverted to participate in treatment in order to get their charges dropped or resolved or expunged, depending upon where you are. They have to be able to voluntarily agree to participate and follow the rules and participate in the treatment in order for that to happen, right? But the limitations of these is that the individuals are often asked to acknowledge their illness and they have to voluntarily agree to do the medical treatment. So what that means is for somebody with anosognosia, it's not necessarily accessible to them because they may not be able to follow the rules. They may not be able to say that they have schizophrenia, right? And so it's very limited. They may not just be well enough to agree to participate. And only certain people are considered eligible. So if somebody has killed someone while they're in the midst of a psychosis, they're likely not going to be eligible for this type of diversion because of the fact that it was a violent crime, right? So it's mostly offered to people who have, gotten arrested for homelessness or a petty theft or something along that level where they don't feel the person is going to end up being at risk. But they're an important part of the system, and we want more of these. Now, when we talk about AOT or assisted outpatient treatment, this is a civil court process. So it's done in conjunction with a civil mental health court. And it's to help individuals with SMI who don't know they're sick to be able to engage. And it holds the providers accountable for helping to serve these individuals. It reduces repeated hospitalizations and incarcerations, and it can prevent the person from getting so sick that they intersect with the criminal legal system in the first place. And because they are being required to stay in treatment, it reduces that duration and the number of times that they go back into untreated psychosis, and that's really helpful. And why do we need it? Because non-adherence is the number one problem that we have, right? It's really frustrating to providers and everybody in the system. And AOT is specifically designed to help these people to be able to stay engaged in treatment with a very person-centered approach, okay? And we all know that there's a lot of reasons for non-adherence, right? They might not have insurance. They might be abusing substances that interfere with their medications. The medication side effect profiles of these meds are awful. I wouldn't want to take them. And, when they're paranoid, it's hard for them to trust doctors and family members and nurses telling them you need to take this medication. And anosognosia, though, remains at the top of the list about why people don't stay on medication. AOT is specifically designed for these people. And the focus that they have when they're bringing the people back in for status hearings and conversations with the judge and the treatment team, they don't just say to them, hey, have you been taking your meds? Because I don't know about you guys, but I've had thousands of these conversations that were not effective and probably hurtful to our relationship, right? And it didn't make our son more agreeable to take his medications. Instead, what they do is they have a conversation about what do you want in your life? What are your goals? They have a hopeful conversation and they find out what's important to the person. And then they engage them to stay in treatment under this court order and have repeated conversations about, hey, have you noticed since you've been taking your meds, you didn't get kicked out of your apartment? You didn't lose your job. You've been able to finish that class and you got a B. Isn't that terrific? These conversations with repeated motivational interviewing questions are really highly effective. Okay. And part of that is from the black robe effect. Everybody respects the judge, right? And when I first started learning about these programs, I really thought it was all about that effect on the participants, the patients. But it's also about that effect on the providers, because when you have this team of people that have come together, they've signed memorandums of understanding that they're going to prioritize these patients, and they know the patient's going to come in and have a discussion with the judge on a Wednesday, and they're responsible for getting a progress report in to the judge and the team by a Monday. Knowing that judge is expecting it, they're more likely to go ahead and follow through and provide that communication back to the judge. So suddenly you have this whole team with a vested interest in the well-being of the person, not just the family members, where most of us, especially early on, we don't have the skills, the knowledge, the expertise, or the resources to provide everything around the person that they really need, not on our own. And the team's engagement really is person-centered. Oh, this med is really causing these horrific side effects. Let's have the peer support specialist go with you to your provider, and you guys can have a more extensive conversation about these side effects and figure out if something could be adjusted, right? Again, it's that accountability piece back to the providers as well. And it really works. One of the questions we get asked is, what if somebody doesn't adhere to their treatment? Did they get thrown in jail? And the answer is no, absolutely not, because the civil mental health court does not have the authority to make that happen. Instead, what they do is they really try to engage more with the patient to figure out, why aren't they engaging? What's going on here? They might need to make an adjustment in the meds. Maybe they need to get them in more frequently for these conversations. They might need to keep them in the program longer. It might be that they've deteriorated and they need to go back in for an evaluation and go back into the hospital to get stabilized enough and then start over. But the focus is all about treatment, and never, ever is it about punishment, because punishment doesn't work anymore for these patients than it would for somebody with cancer. And it works. We have data from multiple programs across the country where it takes hospitalizations down 77%. Length of stays in the hospital tends to be shorter at 43%. Arrests go down 83%. Incarceration rates go down. Homelessness goes down, on and on and on. But this little bit of research is what really got me interested in it. Dan Garza is the doc that runs the program in Queens County, New York. And if you ever get a chance to hear him speak, please do. They found that if they can keep people in treatment for about 12 to 18 months, about 90% of them make that key connection between staying on their meds and being able to stay out of the hospital or stay out of jail. And that tracked for me, because if we think back to like the 1970s, when somebody would have psychosis the first time, they could go into the hospital and stay there for 6 months to a year and a half. They could figure out the right cocktail of medications and have that brain heal up enough so that they could become cognitively aware of their own illness and learn how to manage. And their outcomes were much better, right? That's the length of time of staying in treatment that really works for people to really be able to kind of move forward with their lives. So to me, that made a lot of sense. And of course, if we're keeping people out of that revolving door churn, we're saving money. Okay. And there's advocacy needed around the need for AOT. Currently, we have 48 states in the country that have laws that allow for AOT, but not every state has actually implemented it. And even in states where they have, not every county has, right? So in Colorado, we know that it's not implemented in every single county. And you might be sitting there and thinking, oh, somebody needs to make this happen. We need AOT in my county. And I want to say to all of you today that I spent years in that phase of somebody needs to fix this, and somebody needs to fix this, and somebody needs to fix that. It took me a long time to figure out that no national organization can do everything, everywhere, at every level of government and fix it all. That somebody is me. That somebody is you. That somebody is us. We need to be able to step up to the plate and be part of the solution of building out these programs if this is something that you feel is important to you. Okay. If you happen to be from Massachusetts or Connecticut, please know that we are working actively with groups in each state to get an AOT law on the books. Massachusetts had to get their bills filed by yesterday, and so did Connecticut. And I know it did in Connecticut. I'm still waiting to see from my tracking software if Massachusetts did. That was the plan. So we're working on it. If you don't know if you have AOT near you, you can go to our website, go on to the AOT page on the website, and then you can scroll down, and there's a place where you see this interactive map, and off to the side it says click here to see if you have an AOT program in your community. You can click on that, and there's a list of the programs that we know about, and that can be a place to start nearby you to connect with other people in your state. You can also register to join our AOT Learning Network. They send out newsletters on a regular basis with information about upcoming webinars, upcoming web chats between the various members of an AOT program. Sometimes it's judges getting together, the providers, AOT champions like you and me. And there's always learning going on. We also have our next AOT symposium coming up in March in Annapolis, Maryland. And if you want to learn about all things AOT, and if you want to get in a room of people that are SMI advocates like you and me, and judges and legislators and healthcare providers, AOT directors, it's a very multidisciplinary program all about improving the way that we treat people with SMI and anosognosia. I will tell you, it's our tribe. I've gone to every one of these symposiums and I love them. So I invite you all to think about registering and coming and joining us in Annapolis.